NEI Spring Congress is headed to my home of Florida, May 1st through 3rd, and I hope you'll join me. Come for the latest in psychopharmacology. Stay connected with like-minded clinicians and experts. Walk away with the tools that make a real difference in clinical care. Registration is open now, and spots are filling fast. Use code NEIPOD26. That's all capitalized, NEIPOD26. Register now at nei.global/spring.
Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and chief medical officer of NEI, Dr. Andrew Cutler, sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
This NEI podcast episode wraps up our myth-busting series with a focus on ADHD medications, both stimulants and non-stimulants. I'm talking with my friend Dr. Tim Wilens about separating fact from fiction, from concerns about overdiagnosis and misuse to what we really know about long-term safety and outcomes. Tim, welcome.
Thanks so much for having me, Andy.
Yeah, I'm really looking forward to this, Tim, because as you and I know, been in this business a long time, a lot of myths out there, a lot of misinformation.
There is, and it cycles. And you never know what the myth is going to be. Is it going to be about ADHD? Is it going to be about medication? Is it going to be about long-term, short-term? So I love the idea that we can sort of address it and also give sort of a contemporary view on a lot of older myths.
I agree with you 100%. And as you were saying that, Tim, it occurs to me, other diagnoses, you don't have to necessarily argue for the legitimacy or even the existence of the diagnosis. So there's a lot of misconceptions around that. And then, of course, all the baggage of medications, especially stimulants. Well, let's start talking about some of the most common misconceptions. We'll start with the diagnosis of ADHD, Tim. What are some of the misconceptions out there?
So I would say one of the first misconceptions is that ADHD isn't real. I mean, there's still a lot of people who see this as really a cosmetic disorder, something that, may exist, but it just causes a little bit of difficulty. Kids in school are getting B pluses instead of A's. Individuals at work aren't getting their raises or their promotions, every 6 months instead every year. It's sort of seen in this sort of mild light. And in fact, one of the things we know about ADHD is it's anything but cosmetic. And it has with it real complications, sequelae, that it's really necessitates a good diagnosis and downstream treatment.
Yeah, I sometimes say, I think people think sometimes it's, oh, you're just a little spacey or forgetful, isn't that cute? Well, as you've said, we've now learned about not only the kind of obvious effects on psychologically people's lives and so on, but there's a lot of medical comorbidities and complications. There are even data about premature mortality.
That's right. I mean, when they started looking at actuarial tables, they were pretty surprised to see that people with ADHD, untreated, and we'll get to that a little bit later, are the ones that are at higher risk for everything from just sort of earlier deaths to things like Alzheimer's disease, when you look at those types of risk. So, what I generally say about ADHD is that pretty much every bad outcome, ADHD doubles. It could be anything from substance use, nicotine use, to other psychiatric issues, to blood pressure, heart rate considerations, poor health, things like that. If you don't do stuff for ADHD, you're going to see an increase across the lifespan with a lot of different bad outcomes.
Yeah, I certainly agree. And, a lot of our audience may be familiar with the associations of mood disorders, depression, bipolar with obesity, cardiovascular disease, diabetes, but the same things hold true here with ADHD.
They do. And I think that was a bit of a shock to the field. I think it was a sort of a wake-up call to us to start better looking at health. We're going to be talking about meds later, but we were so focused on what do the meds do in terms of cardiovascular outcomes. Nobody asked the question, what does the baseline disorder do? What happens if you have ADHD and its ultimate outcome for cardiovascular and other health?
I love that when we're evaluating risk-benefit, we should think about the risk of inadequately treating the illness.
I think, Andy, over and over, I think we need to think that. There's the risk of untreated ADHD. And when we talk about treatment, there's the need to treat, and why are we treating? Because if you don't treat ADHD, a whole lot of bad outcomes are doubled or tripled in their likelihood.
including premature death. I mean, you're familiar with the recent O'Nions article out of the UK. It was published earlier this year. Shockingly to me, found if you are a man with ADHD, on average, you die 7 years earlier. Women, 9 years earlier. And we're used to men dying sooner than women.
Yeah, it's that same 7-year chronic illness hit. So if you look at a lot of chronic medical illnesses or lifestyle illnesses, such as smoking cigarettes or vaping, if you look at diabetes, if you look at untreated certain infectious diseases, et cetera, it's a 7-year hit. So it just sort of falls into that same category like any of these other major risk factors that people have that we all know are seriously problematic for longevity and also wellness during that period.
Yeah, I like what you're saying. It's not only a literal duration of life, it's quality of life too. And so again, what we're saying is we're putting this into the house of medicine. This is a real medical, neurobiological disorder. One of the shockers for me, you probably remember a couple of years ago, the famous GWAS study that came out. I would have thought that the most common genetic linkage with ADHD would be depression or anxiety, something psychiatric comorbidity. Turns out it was obesity, elevated BMI.
You know, and what's interesting about that finding is when you look at what happens to individuals over time with ADHD, we've always been, again, it goes back to we've always been very focused on do the medicines, in particular stimulants, cause weight deficits over time. And virtually all the long-term studies show the same thing. No, if you looked at these kids when they grew up to be adults, they were chunky adults. They actually were overweight adults. And then all of a sudden they started to notice that the phenotype itself, that is ADHD itself, is leading to an increase, of obesity. And it's a pretty substantial, they call it effect size, how big the effect is. It's pretty substantial, actually. So we've gone from, we're going to have a bunch of scrawny adults because of their treatments to, we've got to worry about the same thing you worry about in anybody else, which is healthy weight, but maybe even a little bit more so.
Yeah, that's well said. So thinking about monitoring the whole person, their whole body and brain health, I guess I would say. It also occurs to me that when we think about this premature mortality, what are the causes of death? Well, it's interesting, it divides into two categories. There's unnatural, which is suicide, and many people may be surprised that there is a clear suicide risk with untreated ADHD. And accidents, these are people who we know, car and other accidents. And then, of course, the natural causes of death, cardiovascular, diabetes, and so on.
Yeah.
And as you mentioned, they smoke more and drink more, so they have unhealthy lifestyles.
That's exactly right. And one of the things you'll see in clinical practice is when you're working with people and treating them, often you'll find that they get back into health routines that they hadn't had previously. So that all of a sudden they'll start working out or they'll start walking more. They'll start paying more attention to what they eat. We know that some of the treatments for ADHD also can help regulate not only, your affect and your cognition and all of the emotional regulation, but also your eating. And it really helps. Everybody, again, sees the treatments as diminishing, but in fact, it sort of normalizes, it stabilizes eating patterns. So I think you see a contribution of all of that sort of converges to create more healthiness, wellness in treated samples. And again, this is all relatively new to the field.
Yes.
That we're talking about medical complications of untreated ADHD.
100%. You're right. But when I started out in the field, this was purely a disorder of cognition, if you will, attention. But I've been thinking lately, this is dysregulation. Okay, we'll start with that. It's dysregulation of attention and cognition. It's dysregulation of motor activity, dysregulation of emotion, as you said very well. But it's also dysregulation of the motivation reward system and even arousal and circadian rhythm. So it's a lot of dysregulation. There's a lot going on here.
There is. And I think we keep sort of piecing this together over time. And I think the more recent ones, as you were talking about, more circadian rhythm, understanding emotional regulation in context to cognitive executive functioning and dysregulation. A lot of people say we call it attention deficit hyperactivity disorder. And some people say it should really be attention discontrol, or a dysregulation disorder. One symptom is in that rubric, frustration intolerance. But when you think about it, and when you look at this loading of all of the different symptoms that people have who have ADHD, right behind inattention, hyperactivity, impulsivity is dysregulation. Not enough to make the cut so that it's widely part of what we classify as ADHD, how we diagnose it, but it's very critical in terms of taking care of people and understanding all the symptoms they have.
Yeah, you're right. It always bothered me a little bit that emotional dysregulation was kind of relegated to the associated features. I mean, if you look at, of course, the earliest writings around ADHD talked about, stubbornness, frustration tolerance, emotional regulation. And Tim, if you actually look at the neurobiology, what's going on here, the prefrontal cortex actually regulates 3 circuits, not 2. It regulates circuits of attention, cognitive control, regulates motor behavior and impulsivity, but it also regulates emotional reactivity. So I think that having a little more holistic kind of complete understanding, and that leads me to talk to you a little bit about what we've learned about the neurobiology. So as we're kind of talking about the myth of, is this a real disorder and so on, what do we know about the neurobiology that could help us to say, yeah, this is a real neurologic issue, wiring problem?
Yeah, I mean, they have consistent findings. First of all, and this has been replicated very recently in the adolescent brain and cognitive development studies, ABCD, which is the largest study to date, 10,000 kids, 9 to 10 years of age, followed for 10 years. They're looking at a lot of different outcomes, mainly looking in substance use, cannabis and others. But so many kids have ADHD in this study, no surprise that they have all of these sort of snapshots. And so what they found with this and other studies is they see sort of consistent patterns, is to go back to what you're saying, that you do see neurocircuitry differences. For example, as you were commenting, the prefrontal areas of the brain seem to be functioning, but not functioning as well. If you look at the functional circuitry between those and the deeper limbic and paralimbic areas, you see less top-down oversight. In other words, to people who are listening, you don't have the same oversight of your sex, drugs, rock and roll, and emotional centers of the brain. And you commented also about the reward centers of the brain. The reward centers aren't just, hey, I like drugs, I like alcohol, etc. It's motivation. It's what gets you up and getting going and everything. And they found that ADHD reward centers are quite different. They respond differently to stimuli. They respond different to feedback. They respond differently to nicotine even, so that the reward centers are different. So you have different, deeper reward centers. You've got different prefrontal oversight to these reward centers. You have different emotional centers. And then the last thing I'd say that sort of complicates it is we know that the development, that prefrontal area develops over time. You're going to see development up to age 25, some people claim, and in guys it takes 45 to get there, but it takes a while to get there. And what you see with ADHD, there's about 1.5 years or so delay in the development of that prefrontal area. And again, for people who are listening, that prefrontal area, if you put your hand over your forehead, that's where it lives. That's your shock absorbers. That helps you problem solve. It helps kind of dampen the centers of the brain that want this, want that, sort of impulsivity. It does a lot of that, and it's delayed 1.5 years in terms of growth with kids with ADHD as they grow up.
Yeah, that's the famous Shaw study that literally showed delay in development. But what's interesting is they also showed there was not a delay in IQ necessarily, or intelligence. Right. It's more emotionally these kids were less mature in a sense, and this is what can get them into trouble, of course. I really love your conceptualization, Tim, of kind of a top-down, bottom-up functioning here. And so the top-down, of course, is taking in information and processing. Do I really need to blow a gasket around this? Is this really that important? And it just kind of puts those things into perspective. It's also involved, as we know, with executive function, organizing, planning, time management. And these are all things we know people have problems with. There have been a number of great neuroimaging studies that have really shown us, as you said, there's absolute differences, not only in the structure of parts of the brain, but in the function, in the connectivity, in the way that these two parts of the brain talk to each other, for instance. And so we are talking largely about dysregulation. And I love what you said about this is not attention deficit. I've joked for years that all 4 words in the ADHD are wrong. It's not attention deficit, it's attention regulation or moderation, because we know if somebody's interested, they can lock in and hyperfocus. It doesn't have to be hyperactivity. We have lots of people who don't have the hyperactivity, and I don't necessarily see it as a disorder. I see it as a different way of processing information. And there are kind of some things people with ADHD who actually do a little better. There's some situations that brain functions especially well. So what are your thoughts about that?
Yeah, I think that we're always trying to come up with a better way to unify what we understand. And some people would say, well, that's a problem because you're shifting how you see it, and that is proof that it's not really a disorder. And what I would say to that is, no, you're using science, you're using our understanding, you're using now thousands of people in studies and understanding things over time to better refine what we consider ADHD and what happens, what's the course of this disorder over time. It's changed in the past. I suspect it's going to change moving forward. And it also then helps us target our treatments, right? It's going to help us know if you have issues here, we need to think about how do we address those.
I really like that too, Tim. This is a heterogeneous disorder, both in the way it presents clinically. We all know there are different clusters of symptoms and different impairments. And then, of course, neurobiologically, I think we're learning. And of course, our goal ultimately is to personalize our treatments. Frankly, stimulants are still most commonly used. They're just darn effective, Tim. That's why we have to use them. But I kind of feel like it's almost a blunt instrument. It's sort of hitting the brain with a sledgehammer. And it'd be nice to be able to have a little more less targeted, let's say, therapies.
Yeah, I think we're trying to come up with more personalized medicine for ADHD. Biggest issue we have is that we start with stimulants for a number of reasons. Number one, they've been around the longest, since the 30s we've had stimulants. Number two, they work very well for ADHD. They're the most effective agent we have for ADHD. I want to put a qualifier on that and come back to that. And they're super effective, and people know that, both practitioners as well as individuals who are being prescribed them or wanting to be prescribed the stimulant medications. I want to say it's a geeky, nerdy caveat, and that is part of the reason stimulants are the most effective agent is because when they were coming up with the diagnosis of ADHD, there's all these criteria to make a diagnosis. One of the criteria is treatment response. And the treatment response was to stimulants. So there's no coincidence that the symptoms that are used for the diagnosis line up with response to stimulants, because stimulants were used to define the original symptoms that were used to classify the DSM for ADHD. Fast forward a little bit, we have non-stimulants now that work quite well, but they may work on different symptoms that may not be captured with the classical symptom profile of ADHD. So I just recommend to people who are listening, keep an open mind on it. Are the stimulants effective? They're very effective. They're highly effective. But some of the other non-stimulants are also, but their effect may be seen in a slightly different light.
Boy, is that really important and helpful, because I've been talking for a while with all psychiatric disorders that we tend to be very symptom focused, and I get it. You need to have a certain number of symptoms to make a diagnosis. Our clinical trials that get drugs FDA approved, the rating scales are symptom based. But of course, there's so much more to the picture here. And I agree with you that probably the rating scales that we use are really biased towards stimulants. And this may be why when we talk about effect size, the effect size for stimulants is so high, and it's less than that for the non-stimulants, but that doesn't mean they're not doing other things. So I like what you're saying there. We've talked, Tim, about the myths. I think we should just put a pin in the fact. We talked about the myth of the ADHD diagnosis, okay, which is definitely a huge barrier for both patients and some clinicians out there. But now we need to, of course, talk about the elephant in the living room, which is the medication in general, but especially the stimulants. What are some of the misconceptions around the medicines for ADHD?
So I would start by saying, there are concerns that these medicines aren't safe. There's still lingering concerns, just as very generic, the medicines aren't safe short term. And myth number two is we don't know anything about them long term. And then after that, I would say people really focus on stimulants. They're just speed. They're just amphetamines that you can get on the streets. They turbocharge the brain, that they can cause addiction, that they're misused and sold extensively out there. People will talk about non-stimulants as just being non-specific sedatives. You're just sedating kids or adults with the disorder. And then I would, again, come back to the side effects are seriously problematic and dangerous because there's black boxes on them, and that we don't know anything long-term. And I'd say all of those areas, we actually have quite a bit of information that I would say is reassuring as a practitioner.
Yeah, 100%. I mean, I think we need to be honest that there is an issue with the potential for addiction, misuse, diversion, abuse. But my bias, Tim, is it's a little bit overblown, maybe having seen the effects it can have when appropriately used in patients. What are your thoughts around that? And do you feel there's a little bit of overreaction and hysteria around this?
Yeah, I think I absolutely agree with you, Andy, that it's there. I think that we have to be very honest that there is misuse and diversion. The Food and Drug Administration's worried about it. The Drug Enforcement Administration's worried about it. And we are. And I've been doing a lot of research with multiple groups around the country in this area. And we do see it. Now, we have gotten much better at understanding who are misusing stimulants. It's typically college-age students in colleges, people in the trades, people in the military, for example, may misuse substances, but it's typically opioids, not so much stimulants. So it's college students. It's often around social organizations, another way of saying fraternity and sororities. And I'm sure that doesn't surprise anybody. And it's usually used for their side effects to keep people awake at night, or for people who have substance issues or who are using them because they have declining academic productivity, which could be a result of a number of things, including underlying ADHD or neuropsych issues or other issues. So we do know that, but I want to end on a bit of a positive note. That is, there has been an increase in stimulant prescribing over the last 4 to 5 years. And when we've looked at non-medical use of prescription stimulants, that's diversion, or that's somebody using them in a way that they're not prescribed, it's actually very substantially down. So there has been a significant reduction in the misuse of prescription stimulants relative to an increase in stimulant prescribing.
Tim, I was not aware of that. Thank you. That's
really we just published that in JAMA. Okay. We just published that last month in JAMA.
Congratulations. That's a great finding. Well, yeah, I mean, unfortunately, we're coming on the heels of the opioid crisis. And it's a little different because opioids don't have the same legitimate medical use, perhaps long-term, that stimulants do, and they're getting tarred and feathered by the same brush to some degree. Why do you think that is, though, that there's been a decrease in the non-medical use?
Well, I want to go back to your comment, Andy, because I think you're spot on with this concern about opioids. And I'll be honest, I think if we don't think that way as a society, we're setting ourselves up for another epidemic. It was very clear at the beginning of the opioid epidemic that it was prescription opioids, either starting them or abruptly stopping them, that was was really fueling the initiation. I also want to comment that after a while, it was no longer driving the opioid epidemic. It became its own issue. So again, going back, the government is very concerned about that. Our fields are very concerned about it. I think it's a legitimate concern. So our group and other groups, Sean McCabe from the University of Michigan, Brooke Molina from Pittsburgh, others have all been looking at these issues. And the good news is we're not seeing similar patterns with stimulants that we do with opioids. For example, we've just finished a series of papers that have looked at new onset of stimulant medications in young adults or older adolescents. Why that was important is because we kept getting a signal that if you waited to start stimulants, let's say in older adolescents, you actually saw higher risk of substance use, stimulant misuse, than if you started stimulants earlier. And that was concern, is that because you're starting them later and it's a developmental period? Is it because you didn't treat ADHD for 8 years and the damage caused by ADHD led to that? We were worried about that. So we've just looked at all these different samples of new start stimulant medications in adults, as well as stopping stimulants in adults. So if these were stimulants, similar to opioids, if you started stimulants, you should see big rates of substance use disorders. You should see even worse if you abruptly stop the stimulant medications. Guess what? start stimulants, we're seeing actually protective effects, especially through the age of risk. We're seeing lower rates of substance abuse than if you had no treatment for your ADHD. And if you stop stimulants, what we see is a return back to what we would expect with untreated ADHD. We don't see that opioid effect where there's this massive increase in stimulants. These data are replicated now. And because of that, organizations like FDA and DEA have been seeing these, and they've actually been open to increasing quotas where we know that there are shortages in certain products and things like lisdexamfetamine, et cetera. But they really needed to see data like that before they could make those decisions because, again, they have a really strong public health concern that we don't recreate it. I think we have enough data now to say it isn't a recreation. I'm comfortable and reassured based on looking at those data and being part of that, and that it's been replicated by other groups.
Wow. Thank you for what you're doing for the field and what you and colleagues are doing. Also, another difference here, I would say, in a sense, is that a lot of it was fueled, the opioid crisis, by pharmaceutical companies, as we know. And I think now some of the part of the shortage, we'll talk about the shortage issue here for a second. The shortage issue in the past had been the annual quotas of how much of the API, the actual stimulant, was just allowed to be made into medication. And as stimulant prescribing rised, that wasn't keeping up with it. So a few years ago, that was an issue, and people lobbied and worked with the DEA and FDA and got that raised. Now, part of the issue is that nobody wants to be the next Purdue Pharma. Honestly, and I think some of the generic makers in particular have kind of cut back a little bit to not look like they're fueling the fire. So that, I think, is another wrinkle here.
I think, and if I could just comment,
Yeah.
You're so right. Some of the shortage is directly related to the opioid regulation and litigation. So you also have manufacturers who are kind of gun shy. It's not worth it. Their profit margins are pretty low on these generics in particular. And then you have the distributors like McKesson and Cardinal and AmerisourceBergen, who all got major liability and regulation hits because of distributing that. And so they're saying, okay, there could be an increase, but we aren't in any mood to really increase these quotas. And then if it makes it by that, the pharmacies all had issues with liability related to the opioids. So they're very strict on their quotas, and often they're on a 3-month rotation. Literally all it takes when you talk to pharmacies is 2 or 3 families who don't usually get their prescriptions at a pharmacy to go to that pharmacy, and they will exhaust the quota that they had that was set 3 months ago. And it's not like they're in any hurry to increase that quota because it's not to their favor.
Yeah, so there's really a lot of issues around that. Let's talk a little bit about the effectiveness of treatment. And let's talk about not only how effective they are for the core ADHD symptoms, but let's talk a little more globally. What do we know about how effective these treatments are, including some of the things we talked about earlier, some of the medical complications, the substance use, the premature mortality?
So we'll start by saying, as you indicated before, these medicines would not be approved by the Food and Drug Administration unless they were effective in the short term. And most of those short-term trials, and Andy, you've done many of those trials, and if you haven't done them, you've helped design them or you've helped interpret them. But you know better than anybody, they're typically 6, 8 to 12 weeks. 12 weeks would be a long one, with usually an extension. And they typically show nice improvement in the symptoms of ADHD. Often they're looking at some of the associated features, maybe a little bit on executive functioning, maybe some of the comorbidity. And then they start to look at quality of life and some of the early metrics of functioning. It's hard to show a major move in functionality at 6, 8, 12 weeks. But to my knowledge, and you know this better than I do, you do see some changes. You start to see some movement there, right?
You certainly can. I'm thinking about the Vyvanse studies that I was involved with. Short term, we did not see a lot of movement on quality of life and function issues, but in the extension we did. We know that symptoms and function have a strong relationship, but in general, symptoms get better before sometimes the quality of life and function really comes online. But still, that still means that the drugs are effective, very effective.
They are.
Right.
And I think one of the points that you're getting to is a lot of people ask, how much do you aim to reduce symptoms? And I think some of that has been statistically analyzed in a number of studies. I think we used to use 25 or 30%. And I think more people are moving to 40 to 50%.
Tim, I agree. When a mom comes to me and I say, I have great news, I'm going to decrease your kid's symptoms by 30%. That just doesn't sound like a whole lot to me.
It doesn't. And you've been in a unique position of having done depression studies, et cetera. And you've known for years that that's not acceptable for a depression study. And the reason they've moved to 40 to 50% is that's where you can start to really see functionality improve. So I do think that helps. But I do want to return to the real important point about longer term outcomes. And it's another myth. We don't know anything about long-term outcomes. I go ballistic when I hear that. I have to tell you, I get very passionate, partly because I've studied it and I've been part of teams and other people are studying it.
Well, and you've seen patients over time on these treatments. You've seen what they can do.
Absolutely. Absolutely. And we have good data now to show that. We published a paper a few years ago where we looked at the world literature of all major registry studies, did formal meta-analysis, everything. And what was striking, Andy, is that virtually all major outcomes that were assessed, all things we know that ADHD causes, ADHD increases nicotine and substance use and reduces academic performance and causes mood and suicide and motor vehicle accidents, traumatic brain injury, et cetera. All of those were reduced. And the level of reduction it brought it close to, not exactly there, close to population mean, well better than what happens in the untreated state. And they looked at it two ways. They looked at groups that were treated for ADHD and groups that weren't. Interesting, if you did those analysis, 50% reduction in major functional outcome problems. You reduce bad outcomes by 50%. If you compare times when people are treated versus times when people aren't treated, you see about a 30 to 35% reduction in those bad outcomes when you're treated versus when you're not treated. And, and what I want to comment on is it took us a long time to get these data. And, again, I hear criticism about that why wasn't this out earlier? Why did it take so long? Well, I want to remind people that when we were training, juvenile onset diabetes mellitus was a big issue. And there were two camps. One was that you should treat very aggressively, and then you run the risk of people getting hypoglycemic, or you were loosey-goosey. And they did those, and they did all these studies. It took them the same amount of time it took us to figure out ADHD. It took about 20 to 25 years, and they found that tight control of the diabetes resulted in a much better end organ functioning. And because of that, most of the insulin pumps, most of the innovations around diabetes is in kids because of those findings. We are there with ADHD now. We have enough data, a recent study from Europe that absolutely replicates all of our US from Sam Cortesian group showing, again, the same significant reductions in these long-term outcomes that I think that's no longer a myth anymore. And I think now what we need to do is try to understand what defines wellness. What are the outcomes necessary to get people into those states where they really are going to do well from a functional outcome 2, 5, 10 years later?
Very well said. I mean, Tim, is it hyperbolic to say that our medications can literally save lives?
No, they do. They do.
Yes.
Unequivocally, they do. You can show, looking at the number of patients who have different disorders and what those disorders independently lead to, that the medication save treatments. And, Andy, you talked about motor vehicle accidents. You introduced that. Think about motor vehicle accidents, 2 to 3-fold increased risk for motor vehicle accidents. And that gets reduced when you treat ADHD. Again, very close to population health. It doesn't immunize you against that, but it brings you back to normal levels.
Well, Tim, you just reminded me of a patient I had in an adult ADHD study. A woman came in and one of her cardinal complaints was eye candy. And I said, eye candy? And she said, yeah, when I'm driving, there's all these billboards. It's like eye candy. I get distracted. Well, you can imagine her risk. And one of our guideposts, I would say, for therapy was that And very quickly, with effective treatment, she said, yeah, I don't notice the eye candy as much. Well, don't you think that's going to translate into a decreased risk? So my understanding is that, yeah, treatment literally saves lives, it decreases some of this premature mortality, initially through decreasing the unnatural causes, suicide and accidents go back. But longer term, and you said it beautifully, that people can start paying more attention to healthy lifestyle and so on. Longer term, you do see a decrease in the natural deaths.
Yeah. And that's if you were going to say what's the newest sort of findings in this world, it's looking where we haven't looked or even thought to look before in terms of lifestyle, longevity, et cetera. I do think, though, that we have to talk about side effects, that they do have side effects, and we need to keep a close eye on that. So, for example, cardiovascular health seems to be better long-term, but then these meds can tickle the heart. There's been one study that shows increase in hypertension and coronary artery disease. Other studies that show neutrality. Big U.S. studies have not shown that. Our big U.S. studies, in fact, show, if anything, and it goes to what you were saying, maybe a little bit of a protective effect. I'm not sure I buy that, but at the very least, not seeing bad outcomes. But even with that, we know that there's biologic plausibility for that. So we think it's important that people get blood pressures, that people ask about pre-existing cardiac risk factors, ask about any symptoms people have at baseline or when they're on the medicine, if they develop them. They need to be, evaluated and probably referred to other treatment, be it primary care or cardiology, to get an evaluation and things like that. Do I think we need to run scared? No, right. But I think we need to be knowledgeable about it.
Yeah, no, I agree. I'm no cardiologist, Tim, but I think we can treat hypertension. And I've actually diagnosed undiagnosed hypertension in adults because, they didn't check their blood pressure. When they come in to see me, I check blood pressure. And if you manage the blood pressure, you can safely use stimulants in older adults. But
we did a study on that. We took patients and we were using, at the time, Adderall XR, mixed amphetamine salts, extended release, and we increased the dose up to 60 milligrams, so pretty healthy dose. And we had their blood pressure treated. What we found was no new development of blood pressure. In fact, it was quite interesting, Andy. Our hypertension expert, we had a cardiologist who's a head of hypertension, was saying that there was no changes really in blood pressure, which he thought was a reflection that the antihypertensives were sort of absorbing the slight increases in blood pressure that you get with the medications, that it sort of protected against any further increase. So to your point, you can treat, make them normotensive, and then you can go ahead and treat with whatever treatments for ADHD.
Tim, I also believe there's got to be secondary cardiovascular complications about untreated ADHD. In other words, these people are under a lot of stress. They're forgetting, they're overwhelmed, all these kind of things. I have to believe that treating ADHD in some ways may decrease stress levels and do other positive things.
Yeah, I think you're absolutely right about that. I think that's hard to sort of mine that. But again, I go back to studies that were done back in 2011 by AHRQ and FDA, biggest study we've had in the United States. And when they looked at cardiovascular claims and treatment, they saw, to what you're saying, they actually saw odds ratios that were below 1. What does that mean? Actually reduce risk for cardiovascular adverse events or strokes in treated versus untreated samples of ADHD. Now, that included stimulants and non-stimulants. Again, I was like, I don't know what that means. I don't know if I would say that they're, but kind of to your point, it could be that they improve some of the secondary constituents that lead to cardiovascular disease. Like you said, anxiety and other things are very pernicious in driving cardiovascular issues.
Yeah. Well, I think what you just said is so important because that's certainly one of the myths, is that these drugs are so unsafe and cause all these cardiovascular problems. I shouldn't use them in anybody with blood pressure or an older adult. So that really helps bust that myth. But the other myth, Tim, which is, right in your wheelhouse, is prescribing stimulants will increase the risk of substance use.
Yeah. So that continues to be a concern. And I appreciate to talk about it because consistent findings now, multiply replicated, seem to show the same thing. At the very least, treating ADHD with stimulants doesn't increase the risk for substance use. That one, essentially, everybody agrees on that across the world. That's not just in the U.S. It's not just in in Europe, it's in China, it's in South America, et cetera. But these studies also show, and this is something that we've found in another NIH study that we just finished, which is if you look at it dichotomously, does it? Yes, no. The answer, it doesn't. But if you look at early onset, longer duration treatments, you see protective effects against nicotine use of all types, as well as substance use. So you actually see protection. You may not see it if you ask the question yes, no, because some people are only on it for a year or two. But if you're on them on a regular basis, you actually reduce the likelihood to develop substance use. And the level of reduction brings you back to population norm. Again, doesn't immunize you, doesn't mean that you can't develop one, right, but it's like you didn't have ADHD. That's a good outcome.
Certainly. And another public health outcome of that is there's a lot of clinicians who will just never prescribe a stimulant to anyone with any history of substance abuse. And that is unfortunate. And I think these data help us to say, no, someone actively abusing, of course, but someone who is sober, I guess, and has things in place. And what we're talking about, again, is this modulation of the motivation reward system. We talked a little bit about dysregulated eating before, and I want to expand on that a little bit. Our good friend Vlad Maletic, who sadly passed away a year ago, and I were sub-analyzing some of the viloxazine extended release data, and we looked at the adult pivotal trials for the adults, and we looked at the long-term extension, and we were looking at what was happening with weight. Because one of the side effects can be a little bit of a decrease in appetite. And what we found, Tim, fascinatingly was people who had elevated BMI, over time their BMIs came down, and those who had normal BMI did not drop below, as you'd said earlier. And one of our theories we were postulating is there's a dysregulated impulsive eating kind of pattern, and that especially the fact that viloxazine XR but not only modulates norepinephrine and dopamine, but also a little bit of serotonin, which we know is involved with impulsivity and things like that. So a little more work needs to be done on that, but I think it just makes sense that we are now modulating all different aspects of the motivation reward system.
I absolutely agree with you. You also bring up a really important point in terms of analytics. And again, just to be geeky, nerdy, and I apologize to everybody, but I sort of feel obligated. When you look at overall effects on weight or height, it really does help to do what you guys did, which is to say, let's look at the people who started bigger and taller, heavier and taller, and the ones we may worry about, especially kids, the scrawny little kids. And usually what you find is the effects are like not a problem in the scrawny little kids. It's the bigger, chunkier kids who are tall that may have the hits. And so there could be a height or weight transient issue, but it's often those that. And so I appreciate what you said when you stratified your data.
Yeah, absolutely. So, one of the questions, of course, is the long-term effects on growth. We know that there is an issue there, and that needs to be monitored. But I think we're helping to bust the myth here that that you should never use these medications, and certainly not long-term in this kind of thing.
And if I could just jump for 2 seconds on the height weight, I think there's a lot of controversy about height weight, and I think, I'll be honest, my bias is it's much ado about nothing. There are a few kids that you do have to watch. And we check height and weight. Everybody check height, weight. And there are going to be a few that you're going to say, this isn't right. They're losing multiple pounds, 5, 6, 8, 10 pounds, and they can't afford it. And their height trajectory is starting to bend. Those are the kids you take off, time to try something else. But the question is the nuanced effect. And if there's a nuanced effect, it washes out typically by 2 years. And a lot of times that's because people come off their meds anyway. We know that. I love it. Drug holidays. I love the term drug holidays. Who doesn't want a drug holiday? But if you look longer terms, and even in studies, so there was a huge study from Europe that looked at stimulants, the ADolescent study, and they found no impact on height or weight associated, and was powered to look at that. And then there's other studies that show, it's from big Swedish pre and post use of stimulants, no major changes over time. So I think there could be some changes, but if you look at large data sets, not just, there's some clinical data sets that are basing it on 36 patients. That's irrelevant when you look at these large data sets. What they're showing is very reassuring findings that people are hitting ultimate height and weight. And as we started, the weight issue becomes overweight. They get overweight. It's not underweight.
That's right. Well, I want to also address another myth here, and that is that all stimulants are the same. And I think we need to help clinicians understand the categories here. There are basically two flavors, I like to say, of stimulants that we prescribe. There's amphetamines and there's methylphenidates. And they have some similarities in their mechanism, but they have some important differences. And then, of course, there are non-stimulants, which break into a couple different categories. But talking about the stimulants, both of the amphetamines and methylphenidates block reuptake of norepinephrine and dopamine. But amphetamines, in a dose-related fashion especially, can actually start pumping dopamine out. So in some ways, they're more potent, and in some ways, they have more dopamine risk and side effects. And I've always been fascinated. Adderall, if you will, amphetamine, has a higher street value than Ritalin or methylphenidates, which tells you right there. But I think that's important to understand, too, that while most patients will respond to either one of those two, there is a preferential response. Some patients will do better with one than the other, and maybe it's they need that extra dopamine kick or boost of the amphetamine. But also, in my experience, amphetamines have a little more liability for appetite suppression, irritability, and insomnia, maybe due to that. So I think another thing we need to address is the importance, again, of individualizing and personalizing the tools that we do have now.
I absolutely agree with you. And, the Cochrane reviews and some of the meta-analysis that compared methylphenidate and amphetamine kind of talked about what you said there, that I like to think of methylphenidate as a kinder, gentler medicine. Yeah, and it's typically used in kids. We tend to often default to that in kids, and that seems what Cochrane was recommending. And in adults, you often have to use a more potent agent, and so amphetamine tends to be a little bit more potent and has more side effects. As you were saying, in controlled clinical trials, you actually see mood dysregulation as one of the symptoms of amphetamine. You don't with methylphenidate, something you got to watch, and you'll see that. But even then in the families, you have isomeric. I keep reminding people about isomeric chemistry, that the dextromethylphenidate, dextroamphetamine is going to be a bit cleaner than the racemic mixtures, the DLs, and that becomes really important. Then you have short, intermediate, and acting. There are 15, 17 different branded methylphenidate products, 10 amphetamine products. Wow. So, it's both good and bad. The good news is we have lots of new preparations. Bad news is you got to know them if you're treating ADHD, or at least a few of them. Yeah,
it's a little confusing, I agree. My bias over time, having worked on the development of these drugs, is they're all methylphenidate or amphetamine, so the medicine, the chemical is not different. But we've had a lot of improvement in the technology of the formulation and the delivery system to try to get something that starts working early, is smooth throughout the day, and then has a smooth offset, if you will, a soft landing, I like to call it. So, but yet one of the ironies here, in case you haven't noticed, Tim, insurance companies like to practice medicine without a license. And they do tend to force us, I would say, to start out with the generics, which are older preparations. And so getting these newer, more sophisticated, in my opinion, formulations is a little bit more of a challenge. I do want to shift to one other thing we haven't talked about yet, and this is something as clinicians we see and hear all the time, and that's this notion that the medicines will change a kid's personality, make them a zombie or blunt them or something like that. And I think, again, real issue, little overblown. My bias is that can be addressed either through dose or switch of class of medicines. But what would you say?
Yeah, I totally agree with you. And I always tell people it's a no zombie zone. I would say that's like one of the top questions or concerns that parents have and kids do. And I say if there's a personality change, not the right medicine for you. We don't want a personality change. Unless the personality change is subtle and positive. So if you have the class clown who's constantly getting in trouble and partly doing it because of impulsivity and partly because of social cues he's missing or she's missing and put into this position. And if they're treated and they don't do that as much, that's not necessarily such a bad idea. But I do think that it's critical that we think about, the difference in terms of what it does to people. For example, methylphenidate typically can constrict people a little bit more. And you can see, overcognitive focus, et cetera. For those people, I absolutely agree with you, Andy. It's time to either think about going to dextro or just moving to amphetamine. Yeah. Usually that totally eradicates that concern.
Completely agree. That's been my experience as well. Well, Tim, we're running out of time a little bit, so I want to just get to start wrapping things up a little bit. But I think we have to address something else that's a more recent trend, and that's social media, TikTok and other kinds of things. People are getting a lot of their information, frankly, from TikTok and from social media. And this, unfortunately, can magnify this misinformation and these myths. But what would you say about that, and how can we maybe try to address that?
Yeah, I think you'll get a Nobel Prize if you can figure out the social media issue right now. It's I just recently had the opportunity to lead a panel of all of the living U.S. Surgeon Generals of the United States. It was a totally incredible experience, but social media was their number one concern in terms of its impact, positive and negative. They were more focused on the negative with kids. But to go back to what you're saying about TikTok, there could be some good from it too, because there's a tremendous amount of information that's out there, and kids may start to understand that they could have ADHD or other disorders, depression, anxiety, that they could be experiencing other things, sexual gender issues and stuff that they wouldn't have thought about or knew what it was unless they saw it on TikTok. So not always is it terrible. To your point, there is also a lot of opinions on TikTok. I strongly recommend anybody who is listening to this podcast go to TikTok and take a look at some of the things online. It's mind-blowing. I have a son who does social media in terms of he's a digital marketer. So he will expose me to these types of things, and I am shocked. So to your point, Andy, there is a lot of information out there. I think our job is to deliver the information as practitioners in a very thoughtful, deliberative, really non-agnostic way. You don't want to, or agnostic, I should say. You don't want to be biased in your approach to it. You don't want to overvalue either one, but really having sort of a scientific approach. More and more with all of this information, some good, some not so good, it goes back to the practitioner being the one who's delivering the material.
Yeah, well said. And I think we should almost embrace this to some degree in the sense that what I do is I tell patients and families, please tell me what you're seeing. Bring this to me so we can talk about it and try to give you some fact versus fiction, if you will. And then I do try to direct people to more legitimate sources, sites and sources of information. And there's many out there for ADHD, of course. We're, again, unfortunately running low on time. Let's wrap up a little, Tim. Let's see, what are some of the take-home messages here that we can help our listeners? And I wanted to say, Tim, our listeners are not only healthcare professionals. We have lay people that listen to the podcast as well. So what might be some of our take-home messages that we can help people with these misconceptions and myths?
So I would say that ADHD is a real diagnosis. It's clinically diagnosed. We haven't gotten into that, but you can diagnose it. It's very important to get a good, careful diagnostic evaluation for ADD and other things, but that it has a longitudinal course or course over time that can be negative and problematic, and you read about it. The good news is that treatment works short-term and helps obviate many of those bad outcomes over time. Our treatments do have side effects. All medicines do. But when properly managed and oversight, almost all of those side effects can be managed effectively. And we're so lucky now to have a good armamentarium of medications, but also different types of psychotherapy that we can marry to the medications, that I'm actually very optimistic about where we are currently with ADHD. And what we didn't talk about is all the new stuff with ADHD. The field, keep tuned, because in the next 5-8 years, it's going to change. We're going to have changes. And I think that's going to be very positive.
Boy, I so agree. And Tim, as you're talking, I'm realizing how much we didn't get to talk about today, such as the diagnosis. One of my pet peeves is when a mom comes in and said, I had Johnny tested for ADHD, and they said he either had it or didn't have it. There's no test, as we know. Right. So I like what you said about a careful clinical evaluation, taking a lot of things into account, and especially looking for and addressing comorbidities, which we didn't get to talk a whole lot about either. Well, Tim, I completely agree with you. I want to thank you for your time and for the work you've done. I want to thank everybody for listening. Any final words, Tim?
No, other than thank you, Andy, because you're also one of those people that has done a lot of the research and helped us. Many of the products we're using have a stamp that you've been involved with. So
it's very
it's
kind.
It's great to share the mic with you.
Yeah, likewise. Well, I guess I want to also share your message of hope and optimism. I think that we're making a lot of strides in understanding the neurobiology and in coming up maybe with more targeted therapies. So there'll be a lot more options. We didn't get to talk about such things as digital therapies, for instance. We didn't talk about all the non-medication things that are evidence-based. So maybe, Tim, you'll come back and join me again for another podcast and we can talk about some of these other issues. So thanks so much for listening. I want to thank you, the listener. And for more information about our podcast and our other NEI offerings, please go to our website, neiglobal.com. Thanks for listening.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.